Okay, let's dive right into congenital foot deformities. We're going to break down how to diagnose and treat some of the big ones, and we're starting with the most complex of the bunch, Pes Equinovarus Congenitus, or what you probably know as clubfoot.
So first things first, let's really get under the hood of PEC. You see, to have any chance of treating it effectively, you've got to understand all the moving parts, or in this case, all the parts that aren't moving correctly.
Right, and this is absolutely key. We're not just talking about a foot that got a little squished in utero. No way. PEC is a genuine, complex structural problem. And check out those numbers, happening in as many as 1 in 350 births. Yeah, you're definitely going to see this in your career.
So what makes PEC such a puzzle? Well, it's not one problem. It's 4, all rolled into one. You've got equinovosity at the ankle joint, varosity in the hindfoot, excavation happening in the midfoot, and adduction up in the forefoot. Think of it like a 4-part harmony of wrong. And if you want to fix it, you can't just fix one part, you have to tackle all 4.
Okay, so when you first see a foot that looks like this, your first job is to figure out what you're dealing with. Is it positional or is it rigid? Because that's a huge fork in the road. A positional one is flexible, you can correct it with your hands, and it's usually just from being cramped before birth. But a rigid structural clubfoot, that's the real deal. It's not going anywhere on its own. And that one distinction changes, well, everything about what we do next.
Which brings us to the big question, how do we treat it? Let's take a look at the different pathways, which, as you can guess, really depend on which type of PEC we're up against.
So the algorithm here is pretty clear-cut. We always start conservatively. And the gold standard, the one you absolutely have to know, is the Ponseti method. It's this incredible series of casts that are changed week by week to slowly nudge the foot back into position. We only even start talking about surgery if that doesn't work. And if we do have to go that route, there's a sweet spot for timing, somewhere between 6 months and 3 years old, where we'll go in for a full reduction and release those tight soft tissues.
All right, so I think we've got a good handle on PEC. But it's not the only congenital foot issue out there. Let's run through a few others that should be on your differential list. First on the list is metatarsus adductus. This is basically an inward curve of the front part of the foot. Now, if it's a bad case, we'll start with casting, just like with PEC. But here's the kicker, and you need to remember this. Time is of the essence. If that foot is still curved by the time the kid turns 4, casting isn't going to cut it anymore. We're looking at a surgical fix, a metatarsal osteotomy.
Okay, so we've talked about the most complex one, but what about the most common one? Well, believe it or not, it's not clubfoot. The #1 congenital foot deformity you're going to see is Pes Calcaneal.
Think of this one as the anti-clubfoot. The foot is cranked all the way up and out, maximum dorsiflexion and eversion. It can look pretty dramatic. Sometimes the top of the foot is literally touching the shin. But even if it seems a bit rigid, the game plan is usually conservative. We're talking physical exercises, maybe some casting, but generally a much simpler fix.
Next up, talus verticalis. The 2 words you need to burn into your brain for this one are rigid and rocker bottom. It has this very distinct cradle shape because the navicular bone is actually dislocated on top of the talus. This creates a super inflexible, really obvious deformity.
And that brings us to the punchline for talus verticalis. Because it's so incredibly rigid, forget conservative treatment, it's just not going to work. Surgery is the one and only option here.
All right, this next one is a whole different beast. It's called tarsal coalition, and it's basically a developmental hiccup where bones in the foot that are supposed to be separate, well, aren't. They're connected by this abnormal bridge of bone or fibrous tissue. Most often, you'll see it between the talus and calcaneus, or the calcaneus and navicular. For a lot of people, it's no big deal. But if it becomes symptomatic, you end up with a really rigid, painful, flat foot that just doesn't want to move.
So what do we do for the patients who are in pain? It's a surgical fix. The plan is to go in, cut out that bony bridge, and then put something in its place, an interposition plasty, to make sure it doesn't just grow right back.
Whew, okay, that was a lot. So let's boil it all down. What are the absolute must-know take-home messages for your rotations and exams?
Let's lock this in. PEC, remember those 4 parts? Equinosity, varosity, excavation, and adduction. And your go-to treatment is the Ponseti method. Talus verticalis, the buzzwords are rigid and surgery is the only way. Pes Calcaneal, that's the most common one, and it's usually flexible. And finally, tarsal coalition, we leave it alone unless it starts causing problems. Seriously, getting these distinctions down cold is going to be a game changer for you when it comes to diagnosis and management.
And I'll leave you with this one last thing to chew on. With prenatal imaging getting better and better every year, you have to wonder, how is that going to change the game? We might be moving away from just fixing these things after birth and into a whole new world of prenatal counseling, detailed planning, and maybe, just maybe, even interventions before the baby is even born. It's a pretty exciting thing to think about.